Hello, everyone. We are the 1D group from Dash 1, and I am Kyla May Manara speaking, and we are going to present to you our case study on the metabolic disorder hypokalemia. Before proceeding with the discussion of hypokalemia, I would like to introduce the members of 1D. So we have Anda Samantha, Cora Samuel, De La Cruz Lauren, Dulu Camille, and yours truly, Manarang Kyla May, and Diana Punay, Rivera Asian May, Avren Kiambao, Alili Quinto, and Georgina Sula. First, what is potassium? Potassium is the main intracellular cation in all cells and is disturbed unevenly between the intracellular fluid, which is the inside, 98%, and extracellular fluid, the outside. So, potassium is an essential ion involved in neuromuscular excitability. So, low levels could cause muscle weakness, paralysis, cardiac arrhythmias, or even death. Next, what is hypokalemia? Hypokalemia is defined as plasma or K concentration below 3.5 milliequivalent per liter. And the normal potassium level is 3.5 milliequivalent per liter. And also, we always check if the patient is symptomatic and ask for an ECG immediately. So, why do we need to check an ECG immediately? Because there will be ECG changes. As you can see, there is a slightly prolonged PR interval. There's a slightly peak P wave. There is the ST depression, and there is a shallow T wave and a prominent U wave. If you know a normal ECG, you won't see any prominent or tall U wave. It is an abnormal U wave. So if you see or saw in a monitor that there's a presence of U wave, then there's a possible hypokalemia. Symptoms or ECG abnormalities require monitoring and supplementation in a cardiac or critical care unit. Now let's move on to the pathophysiology of the hypokalemia. So as you can see, there is transcellular shift, there is total depletion. What are those? So hypokalemia happens if there is either a transcellular shift from the extracellular to the intracellular compartment, or total depletion of potassium. Okay, first let's dive into total depletion. What is total depletion? So, total depletion, there can be a decreased intake or an increased intake. For the decreased intake, it's either because there isn't enough potassium intake coming into our body through a bad diet or malnutrition or malabsorption. In the increased loss, it is because you are losing potassium. The total depletion is usually through loss. So our job is to determine if it is gastrointestinal or renal loss. So let's see. If it is gastrointestinal loss, it is easy to figure out because we can see in the subjective or subjective data if the patient says that she or he is vomiting or she or he is experiencing diarrhea. And for the renal loss, it can be determined by measuring potassium in the urine, the cutoff being 20 millimole per liter in a urine sample. So for the renal, we have mineral corticoid. So what is mineral corticoid? You know that we all know that in renal potassium handling, it is managed by the mineral corticoid action of aldosterone and by potassium pumps in our renal tubules or tubular. This means that all syndromes that result in increased mineral corticoid activity could result in renal potassium loss and thus hypokalemia. So examples we have hyperaldosteronism, Cushing, licorice, renal artery stenosis, and etc. These patients commonly have hypertension. Moving on to tubular. Loop and thiazide diuretics influence the handling of potassium in our tubules. Also note that there are syndromes mimicking these effects. Okay, diuretics, women, I can remember Sir Tony said the wasting diuretics. Okay, potassium wasting diuretics, which means sinatapon niya yung mga potassium. That can be also a cause of hypokalemia. And then we have the Barter and Gitelman. And we also have you may never forget one thing in the workup of hypokalemia. We always need to check the magnesium levels. Okay, and magnesium is necessary for maintaining potassium levels by blocking the ROMK potassium channels in the distal tubule and thus decreasing potassium secretion in the kidney. So, what do we need to know? These patients usually have or experience hypotension. And for the next slide, okay, moving on to the transcellular shift. Hydrogen ions and potassium ions shift over the cell membrane. That is what we call alkalosis, in which there is low extracellular hydrogen, causes a shift of hydrogen from intracellular to extracellular to compensate. Why does it need to compensate? Well, it is to maintain electrolyte balance in the cell. Okay, so let's move on. But then I wanted to share to you the four causes of transcellular shift. We have alkalosis, and the second cause is hypothermia. Please note that rewarming the patient therefore results in normalization of potassium levels. And also the third cause, beta stimulation. The third cause is the stimulation of beta receptors. So it should be on your mind when your patient is nebulizing with salbutamol. And next, we have insulin, the last cause of a transcellular shift. We all know that insulin brings potassium inside the cell. So, moving on to diagnosis and management. When consulted about hypokalemia, it's crucial to check for symptoms and get an ECG immediately. Okay, the symptoms will be discussed later. And for the ECG, I have discussed to you that a prominent U wave can be seen in ECG if you have hypokalemia. And also, we need to get the lab work done, such as serum creatinine, magnesium, and a venous blood gas analysis for the urine sample, of course, and get a urine sample of potassium and creatinine. And also, we need to check the medications. Never forget to check their list of medications for possible causes like diuretics. If the patient is um, taking potassium, wasting diuretics. And also, we need to check if the patient is taking insulin, nebulizers, laxatives, proton pump inhibitors because of the hypomagnesemia, in case of hypomagnesemia, and etc. So now let's have our next reporters. We have Samuel Corre.
Hello, I'm Samuel Corre. The case scenario: a 30-year-old woman who had been experiencing muscle weakness and 2 days of vomiting and diarrhea was admitted to the hospital. Upon evaluation, the patient urine output is 400 cc cubic centimeter, 70 cc of yellowish fluid vomitus, and watery stools. And her temperature is 38.5, her blood pressure is 90 over 50, and her pulse is 50 bpm, beat per minute. As the patient verbalized, I have been experiencing vomiting and diarrhea for the previous 2 days. My body feels rather weak at the moment. ECG and a potassium electrolyte laboratory test revealed that her potassium level is 2.9 milliequivalent per liter, lower than the normal level, and the U wave on her ECG is elevating. The patient is admitted to the hospital for hypokalemia.
Hello, I am Ali. Next slide. The patient's name is Shane Maliari, 30 years old, female. She is married and lives in Florida Blanca, Pampanga. Date and time of admission, October 12, 2022, 10 a.m. Chief complaint, muscle weakness, vomiting, and diarrhea. History of present illness. 2 days prior to consultation, the patient experienced muscle weakness, diarrhea, and vomiting. Next. These are the additional data of the patient. Blood pressure of 90/50, temperature of 38.5 degrees Celsius, temperature site, axillary, pulse of 50 beats per minute, respiratory rate 25 beats per minute, oxygen saturation 90%, height 5 feet 4 inches, weight 110 pounds, BMI of 18.9. Next. Lastly, the Hospital Information System, or the HIS. Next, reporter.
Hello, I'm Ishan May. I'm going to discuss about the admission. Date of admission, October 12, 2022. And the chief complaint of the patient is muscle weakness, vomiting, and diarrhea. Principal diagnosis, altered electrolyte balance related to active fluid loss, secondary to vomiting and diarrhea. Procedures that have been done for the patient are the urine output monitoring, fluid intake monitoring, potassium blood test, assessment of urinary potassium excursion to distinguish renal potassium losses, and also cardiac monitoring, which are the serial ECGs and or continuous cardiac monitoring that is called telemetry. Next slide. And the significant findings or the lab results of the patients are the urine output or decreased urine output of 400 cc. And the normal urine output is 800 to 2000 ml per day. Decreased fluid intake of 150 cc. And the normal fluid intake is 2.7 liters or 2700 cc. And potassium electrolyte laboratory test, it has a decreased potassium level of 2.9 mg per liter, and the normal potassium level is 3.5 to 5.0 mg per liter. And also the urine potassium creatinine ratio, less than 15 mg per liter, is called the extrarenal loss or transcellular loss shift, and the normal urine potassium ratio is 20 mg per liter. And if it's a concurrent metabolic acidosis, it is likely due to diarrhea. And if it's concurrent metabolic alkalosis, it is likely due to vomiting or diuretic use. And the ECG results of the patient, it has a presence of an elevated U wave. And the clinic physician in charge. And the next reporter will report about the input and output.
Hello, I am Samantha. Next slide, please. Here is the client's intake and output for 2 days of admission. The patient is admitted on October 12 at 10 in the morning. She is given an IV infusion of potassium chloride in 1 liter of normal saline divided into 2 shifts. So a fluid intake of 500 ml of IV fluid and 30 ml of meds, a urine output of 250 ml, a bowel movement of 80 ml, a 60 ml of vomit. Next slide. For the PM shift, she has an intake of 500 ml of IV fluid, another 30 ml of meds, a 300 ml of urine output, 70 ml of bowel movement, and 50 ml of vomit. Next slide. For the night shift, she is given a 50 ml of IV fluid with 600 ml of fluid intake by mouth and a urine output of 400 ml. Next slide. For the next day, October 13 a.m. shift, she is given 50 ml of IV fluid with 700 ml of fluid by mouth and 380 urine output and 60 ml of bowel movement. Next slide, please. For the PM shift, she's given 600 ml of fluid, a 50 ml of IV fluid, and the urine output is 350 ml. For her last day, she is given 700 ml of fluid and she has 400 ml of urine output. In summary, the patient's fluid intake is 1,710 ml and 950 ml of urine, 2 bowel movement, and vomited twice on the first day. A 2,100 ml of fluid intake, 1,130 ml urine, 1 bowel movement, and no vomit on the second day. Next slide, please. The doctor ordered an IV infusion of potassium chloride 40 milliequivalents per hour, diluted in 1 liter of normal saline 4 times a day, or until symptoms resolve or serum potassium level greater than 3.0 milliequivalents per liter. If the serum potassium level rises to 3.0, the patient's dose is lowered to 10 milliequivalents of potassium chloride per hour in 50 ml normal saline 4 times a day. The patient can take fluids by mouth together with IV to achieve the required daily fluid intake. The other medication ordered is bismuth subsalicylate, an antidiarrheal. It is used to treat diarrhea and nausea with a dosage of 30 ml by mouth every 30 minutes as needed. Next reporter.
Georgina and Diana.
Hello everyone, I am Georgina Surya, and for the assessment, the physical examination of the patient, the general appearance is pale, fatigued, and weak. For the arterial blood pressure, 90 over 50, the heart rate is 25, the respiratory rate is 25 beats per minute. And for the allergy alert, no known allergies.
Hello, I am Lauren de la Cruz, and I will be talking about the patient's follow-up visits and client education. Next slide, please. For the follow-up visits, follow up with the patient's primary care physician 2 weeks after discharge for monitoring and to determine if the patient's condition requires additional care.
Physician notes. The doctor ordered electrocardiogram or ECG to examine the patient's heart. The patient was then admitted to the hospital. The doctor ordered cardiac monitoring, serial ECGs, and continuous cardiac monitoring. The doctor also ordered to administer the following drugs: an oral potassium replacement, an intravenous potassium replacement, an anti-vomiting agent, and antidiarrheal medication as indicated.
Hypokalemia is an electrolyte imbalance where the level of potassium in the bloodstream is lower than normal, which can be life-threatening. Therefore, when teaching a patient regarding hypokalemia, the nurse should cover the following topics. First is the signs, symptoms, and complications of hypokalemia, such as muscle weakness, which in severe cases can lead to paralysis and kidney failure, fatigue, muscle cramps, palpitations, polyuria, and constipation. It can also cause low blood pressure, muscle twitches, and mineral deficiencies. Second is the causes and risk factors such as drugs like diuretics, blood pressure medicines or antibiotics, medical conditions such as kidney disease, decreased potassium intake,
transcellular shifts, and increased potassium loss, meaning skin, gastrointestinal, and renal losses. Third is the prevention of future episodes. To help the patient prevent hypokalemia, inform them that diet changes may be needed and also to be safe with medicines such as both of these factors can induce hypokalemia. Next is explain to the patient the relation of altered potassium levels to dizziness, vomiting, and loss of appetite to help the patient understand why these factors are associated with signs of hypokalemia. Then, explain the need for potassium-rich diet. Diet modifications is not recommended for patients who are predisposed to hypokalemia. Since high sodium intake tends to enhance renal potassium losses, teach patients about the establishment of a low sodium and high potassium diet. And lastly, the warning signs and symptoms to report. Teach the patients to call their healthcare provider right away or go to the emergency room if they experience vomiting, fatigue, diarrhea, rapid and irregular heartbeat, shortness of breath, chest pain, muscle cramps, weakness, and paralysis. Next reporter.
Hi, I'm Diana Kailay Punay. Together with Georgina Sula, we're going to report to you the nursing care plan of this case study. Next, please. So in the assessment, subjective, the patient verbalized, I have been experiencing vomiting and diarrhea for the previous 2 days. In the objective, there's a decreased fluid intake of 156 C. The normal is 2.7 liters. So there is a vomitus of yellowish fluid, roughly 70 cc, times 3 episodes per 2 days. There's a diarrhea for occurrences of watery stools over 2 days. Muscle weakness noted upon. The temperature of the patient is 38.5 Celsius. The BP is 90 over 50 millimeters of mercury, and the pulse is 50 beats per minute. And in the laboratory results, so there's a decreased potassium level of 2.9 mg per liter. So we all know that the normal potassium level is 3.5. Below that may cause hypokalemia. So there is the presence of the elevated or prominent U wave in the ECG results. So in the nursing diagnosis, it is altered electrolyte balance related to active fluid loss secondary to vomiting and diarrhea. In the inference, potassium is an electrolyte needed primarily for muscle and nerve tissue function. It plays a major role in making nerve signals that are needed for skeletal smooth muscle and heart muscle contractions. We need potassium to keep the electrochemical balance across the cell membranes because it is vital to transmit the nerve signals. So this leads to skeletal muscle contraction, hormone release, and smooth muscle and heart contraction. The electrolyte potassium is depleted as a result of fluid loss from the body, such as vomiting and diarrhea. In part because potassium actually lost with stomach fluid. Additionally, episodes of diarrhea cause considerable levels of potassium that are present in intestinal fluid to be expelled. Potassium loss occurs, which causes the body's electrolyte balance to change. So in the intervention, so for the planning, the short term goal is after 8 hours of nursing, the intervention will be the patient will be able to normalize the blood pressure, which is the 120 over 80. The vomiting episode will be less for 1 episode per day. Diarrhea will be less 2 occurrences, and regaining of muscle strength. The long term of it is after 48 hours of nursing intervention, the client will be able to verbalize the understanding of the importance of hydration and potassium of the body, free vomiting episodes, diarrhea free and reestablish and maintain normal bowel movement, reduction in frequency of stool, and maintain serum potassium levels within normal range. Next reporter.
And now let's proceed to the intervention. For the independent, monitor for signs and symptoms of hypokalemia, such as fatigue, anorexia, muscle weakness, decreased bowel motility, shallow respiration, dread pulse. And for the rationale for this, hypokalemia can be life-threatening. Careful assessment for its early presence is needed, especially for high-risk patients. For the next one of the intervention, monitor ECG continuously. The ECG can provide useful information for hypokalemia. Patients receiving digitalis should be monitored closely for signs of digitalis toxicity because hypokalemia potentiates the action of digitalis. ECG result in patient with hypokalemia include T-flat waves, depressed ST segments. Pwede pong pababa. T-flat waves, depressed ST segments, and U wave is elevated, may specific to hypokalemia. For the third intervention, monitor the intake and output including urine, stools, and vomitus. And for the rationale for this, careful monitoring of fluid intake and output is necessary because 40 MEq of potassium is lost for every liter of urine. And for the fourth intervention, review laboratory results like BUN, creatinine, and serum. And for the rationale for this, to evaluate the degree of fluid excess and to obtain baseline data. Next. And for the evaluation, sa ano po, dependent. And for the dependent of the intervention, administer the following drugs as prescribed. Number 1, oral potassium replacement. The rationale for this, administered when potassium levels need to be replenished. Number 2, intravenous potassium replacement. Number 3, administer anti-vomiting drug and anti-diarrheal medication as indicated. And for the rationale for this is to minimize the fluid loss. And for the evaluation, for the last collaborative of intervention, number 1, recommend patient to nutritionist to help the client in selecting foods rich in potassium such as banana, fruit juices, melon, citrus fruits, and fresh vegetables. And for the rationale for this, including client in the plan of care elicits participation. Also, potassium-rich foods in the diet help maintain potassium balance. And for the evaluation, short term, after 8 hours of nurse-patient intervention, the patient will be able to, blood pressure will be in the normal range of 120/80. Patient will be able to reestablish a normal electrolyte and fluid. Fluid balance. Vomiting episode will be less by 1 episode per day. Diarrhea will be less 2 occurrences and regaining of strength of the muscle.
Hello, I'm Camille Dulu together with Ms. Aaron Kamya for the FDAR charting. Next slide, please. For the FDAR charting, the date and time, October 12, 2022, 10 o'clock a.m. The focus is altered electrolyte balance related to active fluid loss secondary to vomiting and diarrhea. For the progress notes, in data, the patient reports of vomiting and diarrhea for previous 2 days and muscle weakness. Decreased fluid intake, blood pressure falls 90/50 millimeters of mercury and pulse rate is 50 beats per minute. Decreased potassium level of 2.9 milliequivalents per liter, and a presence of elevated U-wave ECG result. For the actions, assess the client's symptoms for hypokalemia, assess the client's intake and output, including urine, stools, and vomitus. Assess the client's blood pressure. Low potassium intake has been associated with an elevation in blood pressure and increased the risk of stroke and chronic kidney disease. Assess the client's pulse rate. Low potassium also increases the risk of an abnormal heart rhythm, which is often too slow and can cause cardiac arrest. Administer drugs as ordered. Monitor ECG continuously. Again, one of the aspects of hypokalemia is the risk of ECG changes. And lastly, the response. Patients report vomiting has been less by 1 episode per day and diarrhea has been occurrence. Patient was able to regain muscle strength. Patient was able to maintain a normal electrolyte and fluid balance. Patient maintained a normal blood pressure and heart rate. Patient was able to maintain a serum potassium levels within normal range.
Thank you so much, Group 1D from Dash 1. Thank you so much for watching.